I'd like to thank the SAGES Committee for this wonderful opportunity. We have no financial interests or disclosures to say. The prevalence of the laparoscopic technique for cholecystectomy has constantly risen since 1985, subsequently rising to approaching levels of 90% for all cholecystectomies today. This is largely due to well-published data showing decreased morbidity and length of stay amongst the laparoscopic patients. Recent literature shows conversion rates ranging from 4.9 to 20% depending on the emergence of the case. Well-documented preoperative risk factors include but are not limited to increased age, male gender, diabetes, as well as acute cholecystitis. Furthermore, recent retrospective studies have shown that minimally invasive surgical training, which I'll refer to as MIST from here on out for the remainder of the presentation, has also reduced conversion rates. Given the high prevalence of cholecystectomy and the proven decreased morbidity and length of stay amongst the laparoscopic technique, we sought to compare rates at our institution, the University of Vermont Medical Center, as well as identify any pertinent risks, in particular, the effects MIST may have on conversion. We conducted a retrospective study spanning from 2009 to 2016 of all laparoscopic cholecystectomies. Cases categorized as converted to open were derived via formal review of operative reports, and MIST was defined as a completion of a formal advanced laparoscopic fellowship. For univariate analysis, we ran chi-squared on the preoperative risks in the bottom right corner that you can see. We studied these risks in a dichotomized fashion amongst laparoscopic cases versus laparoscopic converted to open. This is a quick schematic depicting our total cohort of 2,810 patients. And the further categorization, as you can see, LC or laparoscopic and OC converted to open with a total conversion total of 139. Again, those are the risks we looked at in a dichotomized fashion. Here's our patient demographics. You can see the risks listed on the left, which match recent retrospective analyses in prior literature. Notably, 40% approximately of our cases were performed by surgeons with formal laparoscopic training, which also met the percentages noted by recent retrospective analyses that looked at this parameter. Here's our main results. Our conversion rate was 4.95%, which is on the lower end of the recent range of conversions. And notably, the surgeons with no formal minimally invasive training had twice the rate of those that had formal fellowship training in our cohort. This slide depicts the percentages for each risk, as you can see enclosed by the rectangle there. Notably, all of our preoperative risks, including the absence of minimally invasive surgical training, male gender, age greater than or equal to 65, as well as urgent and emergent admit types, all had increased risk for conversion. This depicts our univariate analysis and notably our significant variables. And you can see here that male gender, age greater than or equal to 65, urgent and emergent cases, as well as the absence of minimally invasive surgical training were all statistically significant. We looked at BMI and diabetes, and these were not found to be significant on univariate analysis. Our multivariate logistic regression included all the significant factors from the univariate analysis. And as you can see, the preoperative risk factors retain significance with the exception of minimally invasive surgical training, which was marginally significant with a p-value of 0.087. I wanted to investigate MIST further amongst the cohorts, and by doing so, I compared the demographics between the MIST cohort and the no MIST cohort. And what I found was the surgeons with no formal laparoscopic training were largely operating on a riskier subset of patients, as you can see by the percentages. Significantly more male, significantly more urgent and emergent cases, as well as individuals greater than or equal to 65. Despite this riskier subset of patients, I performed further univariate analysis amongst the MIST and no MIST cohorts, particularly for each preoperative risk factor individually amongst each group, and found that the surgeons with minimally invasive surgical training did have a lower conversion rate for each individual risk factor, as you can see including admit type, male gender, as well as increased age. So that brings us to our discussion. It's clear by our data and also recent analyses that there is a downtrend in conversion rate, which speaks to the fact that surgeons are doing a better job in regards to conversion. As well, there's predictable risk factors which patients should be counseled on. I think the issue at hand still remains, are any of these predictable preoperative risk factors alterable? And if they are modified, will they decrease conversion rates and subsequently change patient outcomes? And that brings us to look into myths a little further and the impact that that may have on conversion. And as we've shown it, we did show a lower conversion rate with similar trends found in previous retrospective analyses. In regards to further research warranted, the question remains, is this due to patient characteristics or acuity as we've seen with the riskier subset amongst the no-miss surgeons in our group? Or is it due to the surgical training and expertise of the surgeons? Limitations of this study include the fact that it is a single center study which limits generalizability, as well as the retrospective nature, which made it hard to control for preoperative risk factors, particularly the differences we saw amongst missed and no-miss cohorts. So to conclude, there are downtrending conversion rates amongst laparoscopic cholecystectomies with well-documented preoperative risk factors for conversion. The question remains, is this due to acuity, technical skill, and I think further controlled perspective and possibly multi-centered trials could help elicit this answer. So, just like to acknowledge my principal investigator and mentor, Dr. Wasef Abu Jayesh, as well as Dr. Sean Wren, who helped me with this study. Thank you very much.
Let me just make a quick comment and have everybody kind of take this into consideration. You know, I certainly was in the era where I wasn't trained, Morris Franklin wasn't trained, but we do a ton of it. We have a great experience and all this and that. And the newer, our younger surgeons are not getting any open experience. So the conversion to open for them tends to be hard. And for us, it's not as hard. When we need to convert, it's natural, it's easy. So I can take some of this information two ways. One, that the older surgeons don't have the skills to continue with the laparoscope, or I can look at it is that they're quite comfortable doing it. They perhaps can do a better job open, and the younger surgeons I see a reluctance to do common duct explorations or sending them off for ERCPs as we're going to be hearing. And I see a reluctance to do certain things that we know are ingrained in the older surgeons. It's natural for us, and we have many more alternatives because I'm seeing a reluctance to do cholangiography, ultrasound to look for common duct stones. I'm seeing some changes that I suspect there may be a little less experience involved. Forgive me for interrupting because okay. I think this will spark a lot of comments. Front microphone, please.
I'm Taizo Hibi from Tokyo, Japan. Actually, my question is is in accordance with you. So, do you have any idea of the consistency of the reason for conversion? I saw in one of your slides, and you raised that as your limitation, but did you actually collect the reasons for conversion? And did you find any consistency among surgeons or not?
This was purely retrospective, so I'm knowledgeable in regards to the intraoperative reasons such as adhesions or difficulty visualizing the field, but in regards to the amount of patients we had, I didn't collect that data and was able to interpret that.
Thank you.
Morris Frank from San Antonio. Thank you very much for a great presentation. This question follows the last one to some extent. Was there an increased conversion when it was acute cholecystitis, number one? And number two, did you note any correlation between the time of day that the surgery was done and the conversion rate? Great study out of Houston about 4 years ago that showed a tremendous increase in the conversion rate if it was done after 11 o'clock at night.
Thank you for your questions. In regards to the preoperative diagnosis of acute cholecystitis, I did categorize and look at that data, but I think this is a large limitation of this study. When pulling the preoperative data and preoperative diagnoses, there's oftentimes 3 to 4 for each individual patient, and it was just too difficult to confidently and accurately, in my opinion, organize that data to have that outlook in regards to acute cholecystitis or whatever primary diagnosis they may have come in, if there's choledoco versus acute cholecystitis and what have you. So unfortunately, we didn't have that.
We have time for one more question, please.
And time of the day, no, we did not.
Steve.
Hi, Steve Unger from Miami Beach. I'm part of the Older Surgeons Club. And
Little gray
it's,
in here.
you know, in my case, it's hospital news if I have to convert. So, but I think you've got fertile data to go back and look at and tell us why there were conversions in these cases. And more importantly, were they safe lap choles? In other words, were they converted because of injuries to the common duct or difficulty completing the cholecystectomy itself? So I think there's a lot of data there. And I think what we shouldn't do is have conversion as a concept that this is something wrong or a failure, because part of the safe lap chole protocol is to open and convert when you're having a difficult time. And I think that's important for everybody to understand.
And to speak to that, I thought it was very interesting. One of the retrospective analyses that I had reviewed for the literature review, and unfortunately didn't incorporate into this study, was surgeon caseload. And in that study, minimally invasive training by itself wasn't significant, but the caseload being greater than 100 cholecystectomies was very significant. And that's something we could look at as well. So.
One last question.
So, two-part question. Did you have any data on bile duct injuries during this series of 2,800 patients? And was there a difference related to the missed training? And also, I guess more of a question for, in general, to the panel and the audience. You know, it does seem like, at least in your data, there was a 16% rate conversion for missed for emergency cases versus 25% for non-missed for emergency cases. What that tells me is that these emergency cases, you know, as we all know, these are really the tough cases. And these, I would not consider this a basic laparoscopic case. I think all these are advanced laparoscopic cases. And if so, you know, I think that there's a real disconnect between perhaps the people that are faced with these cases and their level of training for these advanced lap cases. And I don't know if there's an answer to that paradox.
Could you please repeat part one? Sorry.
Did you look at bile duct injuries related to missed training at all?
In regards to the postoperative complications, we're actually looking at that now in another trial. Preliminarily, it meets standard percentages, 0.2 to 0.5% from what we're finding thus far, but not for this study in particular.
Thank you.